Hello, my name is Louise Chawla. I'm a professor in the Community Engagement Design and Research Center in our program in environmental design at the University of Colorado Boulder. I will be your moderator today for a panel of 4 speakers on the subject of nature-based social prescribing and programming, a route to wellness. This event was co-organized by the Rene Crown Wellness Institute on our campus and our Community Engagement Design and Research Center. We're grateful to our sponsors, our 2 units at the university and also the Department of Environmental Studies, the Colorado Department of Public Health and the Environment, the Rocky Mountain Prevention Research Center in the Colorado School of Public Health, and 2 parks departments in the city of Boulder, Parks and Recreation, and Open Space and Mountain Parks. We're also grateful to the Global Social Prescribing Alliance and the World Health Innovation Summit for distributing this recording. Our presentations will be in this order. Dr. Jill Litt from the University of Colorado Boulder and also the Barcelona Institute for Global Health, who will be talking about physical and mental health benefits of community gardening. Dr. Nooshin Razani at the University of California, San Francisco, who will talk about her evaluation of a pediatric clinic parks department partnership that she created. Dr. Ashby Lavelle-Sachs at the Barcelona Institute of Global Health, who will share her nature-based intervention for pregnant teens and teen moms, and Dr. Wesley Tate at the Trauma Foundation, who will compare nature-based social prescribing and programming and its applications for practice. I'm happy to introduce Dr. Jill Litt. Dr. Litt is Professor of Environmental Health in the Environmental Studies program at the University of Colorado Boulder. She's also affiliate faculty in the Rene Crown Wellness Institute at the university and senior researcher at the Barcelona Institute for Global Health. She received her PhD in environmental health from the Johns Hopkins Bloomberg School of Public Health. Her research centers on the intersection of neighborhoods, nearby nature, food-producing landscapes, and health, with a focus on environmental policy and behavioral approaches to improve and sustain healthy eating, active living, and mental well-being in an equitable and just way. Dr. Litt is currently leading a randomized controlled trial of community gardening funded by the American Cancer Society and the European Commission's Horizon 2020 project, named Reimagining Environments for Connection and Engagement, Testing Actions for Social Prescribing in Natural Spaces, or RESETAs. She will tell us more about this project in her talk. Take it away, Dr. Litt.
Thanks, Louise. It's a pleasure to be here. Thanks to our sponsors. This has been a really special opportunity to come together today with the University of Colorado, the Rene Crown Wellness Institute, our sponsors from Environmental Studies, our sponsors from the City of Boulder, our global partners, to really talk about a topic that we've been sort of evolving, generating evidence, and trying to figure out in the big picture, how do nature-based solutions, how can we leverage them to support our health? The place that I kind of jump into the story is through community gardens and what community gardening can teach us and how we can use that information to support nature-based solutions as a health solution, and specifically, how could we roll this information into a nature-based social prescribing program? So I'll talk about what social prescribing is later in the talk. But first, I want to kind of go through, why do we approach health and well-being through a community garden lens? What is it about this setting that can teach us, that can be a model for us to understand health behaviors in populations and how they can be changed through a nature-based intervention? I'll also review sort of what we know to date about the garden's effect on health and well-being, and that evidence base is evolving very rapidly. And importantly, a recent clinical trial that we published in the Lancet Planetary Health provides just another layer of information with a very strong experimental design that is consistent with past research, but now sort of strengthens the evidence and moves us a bit forward. And then how do we build on this information to advance public health practice and policy. So the first chapter, if you will, is why approach health and well-being through the community gardens lens. This is an image I recently took in Barcelona. The beauty of gardens is that wherever you go around the globe, you can find these gardens. And I often say the best way to the underbelly of community is find a local place's gardens. Because when you show up at these gardens, you begin to see people where they're at, where they live, how they interact with landscapes, the resources in the neighborhood. And it is usually very far from kind of the tourist centers. So I often like to do this first to try to get a feel for what community looks like. And gardens are universal. They are something that have meaning I've never met a community where there isn't a garden and where people have strong feelings about gardens. So it is part of this sort of fabric, and it often is informal because there isn't the structure in place to support them from a more formal perspective. But what is it about gardens, and what is the evidence telling us? So first, I want to go over some of the health kind of context. And, as a public health professional, as an epidemiologist, these are the things that we really think about. And one of them is that a very startling statistic is that 60% of adults have one or more chronic diseases: diabetes, cardiovascular disease, obesity, liver disease, and some cancers, including colon and breast. And 74% of adults are overweight or have obesity. And this is kind of United States statistics, but the trends are ever present in countries across the world. All of these conditions are influenced in part by our diet and our physical inactivity. So this has implications for chronic diseases. It has implications for mental health. It also has implications for cognitive health and an overall story of longevity and health span, so the quality of people's lives. We know that stress and anxiety play a role in exacerbating health and well-being, and so we're constantly looking for ways in which we could move the needle on these different kinds of outcomes. When we think about nutrition, as one example, fiber is an aspect of nutrition that's critical to our inflammatory and immune responses. It's key to preventing disease and promoting health. We know that adults should consume around 20 to 38 grams of fiber per day. We also know that telling someone to eat more fiber is like shouting into the wind. Rarely will it lead to lasting change. And finally, what we know is that engaging someone in an activity or space that they love is a good place to start when trying to motivate change. So we often talk about these ways in which we could conduct motivational interviews to find out what people really care about. And when we know that, we can begin to talk about ways to change behavior, including diet and physical activity. Physical activity is something that's crucial for our health. We know that adults should aim to get at least 150 minutes of moderate to vigorous physical activity per week. This would be things like running, walking briskly, swimming, gardening, perhaps. Increasing physical activity helps us regulate our hormones, and that can contribute to which without a regulation of these hormones can contribute to certain cancers. When we regulate them, we keep the immune system healthy. Telling someone, however, to be more active is not an effective way to motivate change. Maybe in a very short-term way, we might see a little increase in activity, but then kind of people fall back into their own habits. Engaging someone, however, in an activity they love, and by the way, might lead to more physical activity, probably will work better and will be more lasting. And finally, stress and anxiety, another area that we're really concerned about from a public health perspective. Stress and anxiety are really important because they impact almost every aspect of human health, and they can lead to increased inflammation, a weakened immune system, changes in heart rate and blood circulation, disruptions in sleep, metabolic dysregulation, and digestive problems. Telling someone to be less stressed and less anxious may actually provoke more stress and anxiety. Solutions that can reduce stress and anxiety are desperately needed to reduce disease risk and promoting health. And under the guise of COVID-19, we know that we have seen the transformation in the population and the impact of stress and anxiety on mental and physical health. Again, begging the question of what can we do to begin to move the needle to reduce these levels of stress and anxiety in the population. Community gardens becomes a model, if you will, a system to study how nature can improve behavior and improve health, both physical and mental health. And the images you see here is sort of along the lines of what I mentioned before, is that no matter where you kind of pivot in the world, you can find these spaces, whether it's Denver or Sao Paulo in Brazil or Barcelona, Spain, where I currently reside. These are meaningful spaces. They always can bend into the kind of texture of a place, which is the beauty of it, and adapt to the kind of norms of a local area. And they can also squeeze in whether it's a formal or informal structure, although we hope that we can begin to bring resources to these systems to help support better living wherever you live. So what do we know about community gardens on health and well-being? This is a model we put together several years ago before we went and decided to do a clinical trial. And the things that are important here is that there is a long process when you intervene on health. If you're interested in chronic disease and mental health, you're looking for interventions that, may have a direct impact on those outcomes, but also importantly, trying to understand the mechanisms of change and the intermediate ways in which an intervention can affect short-term health outcomes like health behaviors such as diet and physical activity, as well as stress and anxiety. In the garden context, we know that gardens, by participating in the gardens, they start to tap into interpersonal processes like self-efficacy, motivation, subjective norms. They're also important in fostering social relationships, which we know is a key process for supporting health and well-being and promoting longevity. We also know that gardens, because of the nature-based aspects of it, tap into people's emotions, the emotional health aspects, their feelings of attachment, whether they love a place, whether they love where they live, the kind of, again, these emotional aspects, the aesthetics, so the tactile, the emotional, the sense of smell, and the ambient experiences that people have. They often talk about this relaxation and the acoustic landscapes and gardens and the bird song, these things that really stimulate people's experiences in these natural places. And the other piece is that gardens as an environmental change create a space where people can access healthy food and a destination in their neighborhoods where they can become more active. When these three things start to get activated through an intervention, and we show this in various studies, it then leads to people feeling like they can start to participate in different kinds of health behavior changes, like changing diet, increasing intake of fruits and vegetables, being more active. And in the gardens context, we show that people go to the garden on foot. They spend 20 minutes walking there, 20 minutes walking home. They might spend an hour in the garden. All of these things add up in the kind of calculus of how people spend time and where they spend time and the intensity of that time being active. And the kind of continuum goes on where we have studies pointing to reductions in stress and anxiety, reductions in obesity, changes in the gut microbiota. All of these things kind of come together to influence health. So this is the general state of the evidence. But despite the hundreds, and it's not an exaggeration, of observational and quasi-experimental and qualitative studies on gardens and health, the evidence overall is considered weak. And the main problem that keeps coming up is, how do we tease apart cause and effect? Is it the garden that causes change, or is it the garden that attracts people who already have healthy lifestyles? And in that case, then perhaps it doesn't matter if it's a garden or something else, because people already have these interests. So we wanted to know whether the garden itself caused the changes in health behavior. And so we initiated this clinical trial, which was funded by the American Cancer Society with our partner with Denver Urban Gardens. And this just kind of shows you our team, and it was not an easy study to put together. It's highly interdisciplinary. And it builds on 10 years of preliminary studies and building relationships in the community to be able to actually do this type of trial. The trial was a two-armed, observer-blinded, randomized controlled trial to explore whether community gardening improved cancer preventive behaviors and reduced stress and anxiety among a low-income, multi-ethnic adult population. This study allowed us to understand whether the differences in behaviors we observed were because of gardening as an intervention rather than the self-selection of gardeners. Some highlights of the study: it began in 2017 and it ran until 2020, although we had an extension because of COVID, and so we worked until 2021. We randomized 291 individuals that were new to gardening. So this study was unique in that we wanted to see if people new to gardening could be successful in learning a new behavior activity, and then what that impact would be on health, the health outcomes that we were interested in. So they were either randomized to the garden plot, so we call that our intervention, or they remained on a wait list, and we used a wait list control. We assessed diet, physical activity, and body measurements 3 times: baseline, harvest, and 10-month follow-up. We used accelerometers, we did random recalls for diet. So we used kind of the state-of-the-art tools to measure these changes. And we provided gardeners with a garden plot, which is about 75 square feet. We provided plant starts, seeds, classes, and support. And this picture is of Palace and Angel, who had been very committed to our recruitment process, trying to engage people to consider our study. So this is just one picture showing some of our materials. So what did we find? So the key results was that we saw gardens had an impact on fiber intake. So one of our nutritional measures, it increased moderate to vigorous physical activity, and it made people feel better. Specifically, we saw that for gardeners in the intervention group, we saw that they increased their fiber intake by 1.4 grams more fiber compared to our control group, which was an increase of about 7%. We saw that gardeners were more active 42 minutes per week, which was almost 30% of the way to meeting international health advice of 150 minutes per week. And we found that the gardening group saw their stress and anxiety levels decrease. And importantly, those who came into the study with higher levels of stress and anxiety saw a greater reduction. Here's just a screenshot of our recent paper in January in the Lancet Planetary Health. This is an open access article, so I encourage you to check out the details of the study. What we learned was that community gardens, as an example of nature-based solutions, can change behaviors that are important for health, even for people new to gardening. These solutions can reach people from diverse backgrounds and circumstances, as the effects did not differ by race, ethnicity, age, and sex. Gardens should be considered a legitimate health expenditure and part of our toolbox for preventing and treating disease and promoting health. And we need to build on this knowledge to leverage other nature-based solutions in our cities for health promotion and well-being, recognizing that gardens may not be for everyone, but the lessons that we learned about how gardens work can be transferred to other kinds of nature-based solutions. With that in mind, we took this information and we put together a proposal to the European Commission to begin to test social prescribing as a vehicle to advance this idea of connecting people with nature-based solutions in their communities and working with the health systems to do it. Social prescribing is a non-medical community referral system, and it could provide a way to make this bridge and legitimize nature contact and nature engagement as antidotes to a variety of health conditions. Our aim is to test and validate different nature-based social prescribing solutions in 6 areas: Barcelona, Cuenca, Helsinki, Marseille, Melbourne, and Prague. And in this image, you kind of see the different areas and different study populations. In Barcelona, Prague, and Helsinki, where we will run randomized controlled trials, we are going to be working with the general population in Barcelona, although vulnerable, highly vulnerable by socioeconomic status. In Prague and Helsinki, we'll be working with older adults, one where older adults are still living at home with caregivers, and the other in Helsinki, where they are now in residences, so senior centers. In Marseille, Cuenca, and Melbourne, we are working with using pre-post designs, working with people in high-risk areas in Marseille, so immigrant families, recent immigrants, highly vulnerable people from a socioeconomic perspective. In Cuenca, it's older adults over 65. And in Melbourne, it's LGBTQ and refugees and asylum seekers. So this is culturally and linguistically isolated community, working with NGOs in this area, and providing insights into a younger, kind of highly at-risk population who would potentially benefit from a nature-based social prescribing intervention. To do this project, we are deeply reliant on a co-creation process because of the local context, the cultural variation, the different kind of social systems in place, and the range of nature-based activities. It was important that we engaged with our citizens and stakeholders in each of these 6 cities to understand the capacity to address loneliness. And this is a point I did not make earlier, but the main focus of this project, the Reset-This project, is to focus on loneliness and looking at the intersection of nature-based solutions and the care environment. This is a snapshot of a menu that we put together in Barcelona using our co-creation process. And this we will do and replicate in each of the neighborhoods we're working on. In Barcelona, for example, we will be in 10 neighborhoods, and each neighborhood will have its own co-creation process. Each neighborhood will generate this type of menu. And then the idea is that once these menus are in place, we would work with our groups, again, using randomized controlled trials or pre-post design, where groups come together, facilitated groups with trained personnel, 6 to 8 people in each group, and we meet with them over 10 sessions, 1 individual meeting plus 9 group sessions. And this intervention is based on an intervention called Circle of Friends, which is really bringing people together with trained facilitators to address loneliness. But we're using these individual sessions and the group sessions to begin to alleviate loneliness and to give people the skills they need to be able to manage this, make friends, to kind of build their sense of purpose and really build self-esteem and self-efficacy for addressing loneliness, but not to do it alone. And so this is where we have this group-based intervention. In total, we will be looking to recruit 1,000 participants in 2023. So we've initiated those studies, and our main outcomes will be loneliness using the Geerveld scale and the scale 15D for quality of life. So just to bring these concepts together, we know that the evidence-based supporting gardens as a health intervention continue to strengthen. With strong partnerships, a bit of vision, and determination, gardens and other upstream nature-based solutions can offer legitimate ways to promote health and well-being. Solutions must reduce barriers to access due to socioeconomic, demographic, and geographic and cultural factors. It's important to keep in mind when designing these interventions that direct participations with a tactile experience, time outdoors, time together with others, some group facilitation and cultural sensitivity are key to creating an intervention that is set up for success. Nature-based social prescribing may offer a way to bridge these medical systems and nearby resources for the promotion of population mental health. These are just some references just to provide examples of some of the evidence to support what I discussed today. And I just want to thank you and also point you to some resources to learn more about Reset-This, more about our clinical trial in Denver of gardens, and just a way to stay in touch. If you have questions, ideas, if you have a potential community that might be appropriate to kind of work with us and join our Reset-This network, we would be more than thrilled to engage with you.
Yeah. Okay. Thank you very much, Jill. And I see from your slides, you had showed the groundbreaking study with the randomized control trial, which was focusing on health measures we're all very familiar with, physical activity and healthy eating and stress and anxiety. And the topic of loneliness, I gather that from the international scale of this study, this also now is a rising problem globally. It's considered an epidemic here in the United States.
That's correct. And we were interested in focusing on loneliness because in the Gardens research, we really, through our qualitative studies, we kept hearing about people's, that the Gardens just made them feel connected. It made them feel less lonely. And it gave them a place for social support and a place to be successful. And so although we came at it from a health behavior perspective and we're interested in physical activity and nutrition, what we zoomed in on was that the social relationships were one of the key levers to making gardens successful. So people often ask, if I garden at home, would I have the same benefits? And I think what we've seen in some of our studies where we were able to compare home gardeners and community gardeners, and we also compared them to non-gardeners, is that we saw kind of a continuum, like a dose response. And so as the social context strengthened, the effect of gardening also strengthened, almost amplified. So home gardening is beneficial. We see increased fruit and vegetable intake. We see more physical activity among home gardeners. But when we look at the community setting, we see very high scores of aesthetic ratings, of social involvement. We saw more impact on self-rated health and just almost every indicator we looked at. So there's something about the garden, the community garden context that's amplified. So I would say, if you want to garden and you don't have time to go to a community, definitely start with containers, find a parcel of land at your house. There will be benefits. And then if you put it in your front yard and you engage with neighbors, you're now like amplifying it even more. And in the community context, if you're really looking for social connection, this is the thing, the lever that really kind of gets the engines going.
Well, thank you. And we look forward to the next chapter as you begin to present the results from Recetas.
Thank you.
Thank you very much. Our next presenter is Nooshin Razani. She's a doctor and associate professor of epidemiology and biostatistics in the School of Medicine at the University of California. In her practice with the University of California, San Francisco Benioff Children's Hospital, she established a Center for Nature and Health and created S.H.I.N.E, Stay Healthy with Nature Every Day, which connects low-income clinic families with nature through a partnership with the San Francisco Department of Parks. She conducts and publishes research on the S.H.I.N.E model and its impact on patient well-being. And welcome, Dr. Razani.
My name is Nooshin, and I'm a pediatrician and a clinical scientist. I will be highlighting today, there we go, my clinic's work with our regional park in Alameda County, California, as a case example of a partnership between a clinic and community. Then I'll review our work with San Francisco Department of Public Health and local park districts in San Francisco, as well as our current work with the California Health and Human Services to integrate nature into the systems of care. So my clinical work is at Children's Hospital Oakland, but it's actually in the primary care clinic, which is an FQHC, a federally qualified health center, which means that by definition, we serve a low-income population. Patients have to qualify for Medi-Cal or be uninsured in order to come to us. And so in this context, what we're really doing is trying to understand the complex factors at play, which encourage or prevent vulnerable populations from being active in nature. And while there is this growing body of evidence really suggesting that living in close interaction with nature is beneficial to health, if you look at maps of life expectancy, and which is the map on the far left, the way I see it on my screen, and then maps of access to parks and green space, and this is one that I got from Trust for Public Land, and then a map of toxin exposure, which in California we have mapped and anybody can access these data. If you overlay these, what you see is that it's the same people who have a lower life expectancy, who have less access to tree cover, and who have more exposure to toxins. And so in that context, when we were actually approached by our regional park district to give park prescriptions, there was initially a bit of pushback from the clinicians. And what we did is talk to the clinicians during our faculty meetings and really understand what people were saying. And what folks were saying is that it's not for lack of a prescription from us that patients aren't outside, but that we need to facilitate access to nature. And that would be through transportation, food, and we knew about food largely because of the work of Nina Roberts, also because a lot of us are from communities of color, but Nina Roberts has shown that eating outdoors is something that resonates with many cultures. The clinicians wanted their patients to receive a very warm and personal welcome and opportunities for relationship building over time, and they wanted programming that was consistent, reliable, and predictable. And we were very lucky that our park partners basically said yes, and they kept listening to us. In 2012, when they approached us, we actually first, the clinicians asked them to bring nature into the clinics. And so what they did was install these big posters of redwoods, and each clinical area, which was called a pod, was named after a different local regional park. And we made little schematics with maps. And these are very big posters. They are actually kind of like art installations in each clinical room, which is very important because there's not that much opportunity to change signage in a very busy clinic, and people tend to ignore things that are just flyers. By 2014, they actually did start offering transportation, and we started monthly nature outings. And at that time, we had a paper prescription with a map and bus routes, and we also had a nature journal that people could mark their time in. And our indication for a prescription was very broad. Over time, and I think you'll find that in many clinics, these paper elements just went away. And the most important thing that we have now is a question in all primary care visits, a prompt in the EMR, electronic medical record, that reminds the clinician to ask whether the patient has access to safe outdoor spaces to play. And if the answer is no, then they're prompted to do a referral to our program. And that referral is just a button, just like as if they were referring them to orthopedics or, dermatology. They can refer them to S.H.I.N.E, which is the name of our program. We've now been 9 years in of monthly nature outings. What we do during the outings are really stay true to the values of inclusion, cultural humility, and keeping the outings very developmentally appropriate. And that was actually very hard for me to stand up for, because there's a lot of pressure to take up the time with programming that is more obesity related or very structured. And as pediatricians, we really appreciate the different ages and stages, and we really closely protect the free unstructured time and the opportunity to have moments of awe that are free. These are some photos of our outings, and one other thing that was very important to us is that it's a family-based program, so we can have one index patient who's prescribed nature, and they can bring their whole family. So for some people, that's one caregiver, and for, I think, our biggest family, it was 10 people that came with them. And now we have medical residents and a psychiatry fellow rotating through with us every month. We did a randomized trial initially on the program, and we enrolled 78 parent-child dyads, and these are all low-income families. And we saw that receiving a PARC prescription and participation in the program increased weekly PARC visits. It decreased parental stress and loneliness, as well as cortisol and physical activity. But the decrease was small. It was significant, but it was a small decrease in stress. And that really brought home for us that people really need routine, regular visits throughout a week, because it was a dose-dependent small decrease in stress for each PARC visit. In the children, we measured resilience through something called the brief resiliency score. And 54 of the kids were above age 7 and were able to fill out that score. And their score improved with each 1-day increase in PARC visits that the family reported per week. And we controlled for early childhood diversity and stress. We did show that that increase in resilience was, I'm sorry, I said their score decreased, but I meant their resilience increased, and that was mediated by a decrease in stress with each PARC visit with their family. The interesting finding that we had is our 2 arms of the study both received a PARC prescription. One received a PARC prescription to go on their own, and one received the PARC prescription with bus and food and programming. And the group that received the independent PARC prescription actually had a bigger rise in reported PARC visits per week. And maybe during the Q&A, we can go through some of the reasons why I think that happened. It turns out that people who went to parks more after the PARC prescription had a higher baseline nature affinity. And over time, they had more of a change in knowledge where to find parks, their perception of having money to go to parks, and time to go to parks. So that is one example of one specific program. I've also been involved over the years with something called Healthy Parks, Healthy People in the Bay Area, which is an effort to bring together park districts and health departments across 9 Bay Area counties. And in San Francisco, we were able to, after we brought together all the parks, and they committed to doing consistent programming on the first Saturday of the month, and to just being called parks, so that the healthcare providers didn't have to worry about which park it was, or and they provided one consistent logo for that programming. And then in response, we trained the Bureau of Maternal and Child Health, all the different clinicians there who range from midwives to auxiliary health workers to MDs, to prescribe those Saturday events. And in preparation for those prescriptions, we did a training, and in leading up to that training, we surveyed the staff and also did some qualitative work, just to understand how they thought that their patients could better access and benefit from Nature for Health. And what we found is that they had extremely deep answers. And this is a figure that we put together, which was actually, if you took everything that they recommended, it was basically a socio-ecological model. And while they really recognized the value of an individual intervention to increase time in nature, which is basically what a PARC prescription is, they really felt that that was of value to them if it was attached to interventions at other levels, such as interpersonal, community, and societal levels. And you'll see here on the left some pictures of things that happened in San Francisco. So the bottom one is a nature prescription program that happened in one of the public health clinics. And you'll notice that the mom is holding a map, and what that clinic did before starting the prescription program is to do a ton of key informant interviews to inform a map of socially acceptable green spaces for families, instead of just giving them the name of parks that clinicians may not know well. And then the second photo is of a community intervention which was in partnership with a clinic, but was not purely prescription-based, but was advertised in clinics and was working on social norms. And the third one up is actually a public service announcement that the parks made with me that played during Warrior games and got so many views, which was a little embarrassing for me, but it was working again on cultural shift and social norms. And then the top photo is of our Healthy Parks, Healthy People meetings where health and park administrators would meet. And those became extremely important after COVID, when the healthcare providers were able to serve as support to park systems as they were deciding whether to stay open or close. I won't go through this in too much detail, but their responses did help us create a logic model for how to do this. And one really important thing is that most of the clinicians really would talk in terms of giving warm handoffs and expecting feedback about their patients, which was not always a concept that the park providers had been thinking of. So the third thing that I'm going to go through is my current work, which is working with the California Department of Public Health on their ACEs Aware initiative. And so ACEs are adverse childhood experiences, and decreasing those and decreasing the really staggering impact of those on the life course is one of the major platforms of the Office of the Surgeon General in California. And if you look on the right, the Surgeon General's office made a stress buster wheel, which came out during COVID. And thanks to the work of many people who I'm sure are in your room and also in California, Experiencing Nature is one of the 7 stress busters that's being promoted by the state, which I think is a huge win for us. We did a white paper for this initiative where we surveyed healthcare providers and what we are calling nature providers, and I heard that Dr. Chawla calls them nature providers too, which are people that help connect people to nature. And we received responses from 200 healthcare providers and 200 nature providers throughout 50 counties in California, and others from outside of California, but I'm just going to present the inside California data. In general, there was high interest in collaboration on both sides. People working in the outdoors are really, and this survey again happened during COVID, but are really on the front lines of ACEs and taking care of people who are experiencing ACEs. And people in clinics are in real acute need of community partners to help them deal with severe health needs that are happening. And so, when we ask nature providers if they're interested in working with clinicians to collectively focus their expertise and resources to address childhood trauma, 80% agreed. And when we ask clinicians if they're interested in integrating nature into clinical care for ACEs, 85% agreed. I think a really important finding for us in healthcare was that need for trauma services in the outdoors is high. And I don't think doctors and public health departments really understand how much outdoor providers are on the front line for trauma. 80% of the outdoor agencies we talked to saw an increase of use and need for outdoor spaces during the time of our survey. And they expressed that since the start of COVID, their agency has seen an increased need to help heal the impacts of trauma on the communities they've served. And so many of them talked about the real need for trainings on how to best interact with and serve people who have experienced trauma. But there was a real gap in terms of bringing these two industries together. And there's a real need to create shared vision and shared language and to build capacity for true partnership. In terms of nature providers, when we asked if their organization uses a trauma-informed approach to dealing with clients, 53% agreed, Some agencies talked about the fact that calling the police is their first line of response to acute behavior that might be related to trauma, and that there was a need to work with social workers or others to help them interact with closing of the loop that healthcare providers were looking for, and about half agreed that they could. On the other side, when we asked healthcare providers if they understand the evidence base on nature and stress in particular, only about half agreed. When we asked if they felt comfortable discussing time in nature with patients, and this was for the purposes of ACEs, 44% agreed. And then when we asked like even more nuanced questions about nature, which for us at Children's Hospital, when we do motivational interviewing or really do case management about helping people get outdoors, these are the types of things we talk to patients about. The responses were very low. For example, I can discuss the cultural or historical connections my patients may have to nature, about 21% agreed. And I'm comfortable discussing the ways in which racial discrimination may make my clients feel uncomfortable in natural settings. And while a lot of people felt moderately comfortable, 20% of the providers just felt uncomfortable even bringing that topic up. So that was a brief overview of our project and some of the work we're doing with local cities and states. And this is definitely not done all by me. I really would love to thank the fellows, residents, and other providers, as well as our funders in this work. Thank you.
Welcome, Dr. Sachs.
Hi.
Ashby Leavell Sachs is a postdoctoral fellow for Recetas, where she works with Dr. Litt at the Barcelona Institute for Global Health. That's the project that Jill Litt was just talking about. She recently received her PhD in environmental studies at the University of Colorado Boulder, working on loneliness, teen parents, and prescribing time in nature. For her dissertation, she served as a graduate research assistant on the Meeting in Nature Together, or MINT study, funded by the Renee Crown Wellness Institute at our university, which she will talk about today. Prior coming to the University of Colorado, she completed a master's fellowship in public horticulture with Longwood Gardens and the University of Delaware. And she worked in botanic gardens and public park systems in the United States and United Kingdom as a horticulturalist, educator, administrator, fundraiser, and researcher. And welcome, Dr. Sachs. And
Thank you.
You share your MINT study with us.
Okay, great. Let me go ahead and share my screen. Okay. All right. Does that look okay on your end? Okay, great. Well, thank you so much for having me. I'm really excited to share the MINT study with you that was part of my dissertation at CU Boulder. And this is the Meeting in Nature Together study. And I'll describe a bit of it today to see what we found in the past several years. Just a quick note, this dissertation project was funded largely by the Renee Crown Wellness Institute. So many thanks to the Renee Crown Institute and a number of other grants through the University of Colorado Boulder as well. So this dissertation, the MINT program, is divided into two separate studies that I'll describe today. I'll describe both of the studies in this presentation, and then I'll give a synthesis of what we found in the MINT program. So to begin, the first part of the MINT study that I'll describe is chapter 2 of my dissertation. In this chapter, we ask the questions: can a school-level, nature-based social intervention reduce loneliness amongst pregnant and parenting teens by promoting nature and social connection? And we also wanted to know in this study, how acceptable was MINT to our participants? How well did it go, and how could it be improved? So just to begin, what is MINT, Meeting in Nature Together? So essentially what this program was, we partnered with the New Legacy Charter School outside of Denver, Colorado. This is a really special school because it is specifically designed to support both pregnant and parenting teenagers in the region. So what that means is they have special parenting classes available in childcare and all sorts of support for young parents and their peers. And we met with the social workers at the school in 2019 to build the partnership. And they mentioned that what they really needed was help with elective courses at the school. So for my dissertation, I designed an elective course called Meeting in Nature Together that was designed for the students to they would get credit for participating in the class, but they would also get certain benefits like bus passes and gift cards for participating. So for this MINT program, we recruited 17 students in 2020, and we had to switch quickly for it to be an online program in the fall of 2020. However, this worked really well because our students were stuck at home, taking care of their kids and trying to do online schooling. So we found that the MINT program was a really great way for them to meet together online for an hour on Mondays. We would get together, and during that time, we would review nature walks that they went in on their own. The students would take pictures of nature. We would come together and look at the pictures together and do a bit of discussion. We would also do nature-based mindfulness and journaling. And we had guest speakers talk about non-dominant populations' experience in the outdoors. So this was a really great program. And in 2021, by the time spring came around, we were able to meet in person as the pandemic started to lessen, and we would go on park walks together once a week, in addition to the weekly meetups online. So MINT was a structured program that's theory-based. The curriculum included, like I said, discussions, park walks, mindfulness, all sorts of different aspects that were designed with the aim of building a connection to self, to others, and to the natural world. We had a lot of different ways to collect data in the study. Some of them are listed here for this first chapter. All the sessions were recorded and transcribed online. We did a pre and post questionnaire with participants. I also wrote field notes of my observations after each session. I filled out a facilitator evaluation form after each session to feel how close the session was to what was planned in the curriculum. And we also recorded attendance. And this is a bit, just some images I really like from the program. This is some students' journal excerpts that they wrote. We would meet together in the spring and sit by this creek across from the school, and I would give them a journaling prompt. We would write and then talk about what we wrote a bit together here in this park. For MINT this is a mixed methods study using a lot of qualitative methods as well. So for those of you who aren't familiar with qualitative analysis, what that means is I take the transcripts of the recordings and I looked at them with a second coder. We uploaded them into this special software called Atlas TI, and we would look through them line by line together and code and try to find themes and categories within the transcripts that we could draw conclusions from. So what did we find in this chapter talking about how well MINT went, how it could be improved, and how it went? And what did we find in this chapter? We basically, as I mentioned, with the demographics, we had 17 participants total recruited in both the fall and the spring cohorts, average age 17, mostly women, most living with their family, and most were Black or Hispanic. So surprisingly, 100% of all the students that participated in MINT and filled out a feedback form gave us positive feedback about their experience. I really was happy to see this. Some of the stronger themes that came through in the feedback from our participants were the mindfulness and wellness aspects really resonated with participants. They were under a lot of pressure at home in the pandemic with parenting, so they were really drawn to these meditative aspects that we had in the program. In addition, the participants seemed to really enjoy nature photography. They loved having this creative outlet, and it was also a really great way to stimulate conversation in the group. So any of you who work with teens, you know that sometimes it's hard to get young teenagers to open up. So by using the photography, this photo elicitation method, what that means is just using the photographs as a prompt to talk about either their connection with nature, or what was happening in their lives, or their issues with not going outdoors, or what they preferred when they did go outdoors. That was kind of the elements that we found there. Also, we found that MINT provided the opportunity for participants to connect with each other and feel a sense of belonging. I'll share some quotes from that next. It also motivated participants described feeling a deeper connection to nature. And with all of that in the backdrop, understanding that participants in the program needed a lot of emotional support in the pandemic. Students would come to me with on our walks in nature and just describe really difficult things they were going through in their lives. So it was almost just the least that we could do in this program is just try to provide some support for when much more was really needed. Some quotes from our participants. A young woman said, "I felt like I was being cared for and that I was part of the group." Another woman said, "I never thought I would feel so good with people that I barely knew." A young man who described meditation, he said, "I feel good and stress relief as soon as I go outside." And he said, "I feel more active when I come inside." He said nature makes him feel more creative and also good about himself. And at the end of the program, we were able to have a sort of a photo celebration with the students. And at this time, I was also just about to have my own first baby in May 2021. So me being very pregnant at the time, it was a really interesting experience of reciprocity with the participants, as the young moms who were about 20 years younger than I was had already been through childbirth, and they were explaining to me how that went for them and asking me really pointed questions about it. So I really enjoyed that sort of sharing and learning. And this first chapter of a dissertation has been published in International Journal of Environmental Research and Public Health. If you'd like to learn more about the curriculum and how it went, you can check out this paper. And okay, for the second and last study of this presentation, this is the more data-driven version of the dissertation MINT study. So in this chapter, I asked, what are the key ingredients to a nature-based social prescription for a population of young parents and their peers? So if we're going to create a nature-based social prescription for this group, what should it look like? That's what I wanted to ask in this question, in this chapter. So along with that, we wanted to know, what are our participants' preferences for and barriers to spending time outdoors with others? So this chapter followed what we call a sequential I forget the right term. It's a technical term describing using qualitative methods first that lead into quantitative methods. So the phase one of this paper was what I described earlier, the MINT program. So it's sequential exploratory design. I'm sorry, it just came to me. In phase two was we did a cross-sectional survey with 130 young moms at the Young Mothers Clinic of the Children's Hospital of Colorado. So I'll describe how phase one led into phase two and what we found in this study. So phase one, I already described. These are some of the pictures that the students took. I wanted to just show you a sample of them. So each week on Mondays, we would get together during the pandemic mostly, and I would upload, the students would text me their images they took on their nature walks and their nature explorations throughout the week. And then when we would get together on Mondays, I would upload the photos and I would give students a prompt and we would talk about them. So for example, I might say, everyone look at all these pictures together from the week and your prompt is "I wish," that's it. And then they would have to sort of journal a paragraph about what "I wish" meant to them looking at these pictures. And then we would talk about it. So it's a way to like understand better their experience with nature. And I mentioned the qualitative analysis earlier. This is a bit what that looks like in Atlas TI software. So you can see there's some quotes here. I did change the names. And you can see we add these tags here. So this I coded as family, social, family as friends. And then those are all collected into different categories. And then we can kind of visualize them and network them like you see here on the top left. So just a little note about how that works. I'd like to show you some quotes now from this qualitative analysis that we found with the photo elicitation. One of the main themes that came out of this study was that family as friends. So what that means is we found that students spent more time with their immediate and extended family than they did with someone you consider just a friend from school. And this might be due to the families helping raise their babies, or maybe due to partially to the pandemic, as we were all spending more time at home. But a lot of what the students described with how they like to spend their free time was time with family. And I really like this quote a young woman said in response to the "I wish" prompt: "Wish I could lay in my yard with my baby and look at the stars and the moon. I've always wanted to do that," with looking at this picture. So that's just something so simple and beautiful. I love that quote. Another theme that came out similar to the feedback survey I described earlier, the mindfulness and contemplative activities really resonated with the students. And a young man who had gotten away from meditation mentioned in one of the sessions, he said, I need to get back to that being meditation because that's the only happy place I have. It just really makes me feel stable. It calms my mind for when I overthink, because I tend to overthink a lot. I think we can all relate to that feeling. And lastly, the third and final theme from this photo elicitation study was nature close to home. So this idea that nearby nature was something students are really focusing on. And we know from research that nearby nature has compelling health benefits as well, as similar to nature in a more remote setting might have. And this also could be partially due to the pandemic, students staying close to home. But something we did find was that participants had transportation challenges in getting to larger parks or outdoor areas. So nature was really experienced on the block or neighborhood level. And when I asked students what nature meant to them, this young woman said, I think it's something in my backyard. I feel like it's everything and everywhere. I just feel like it's trees and animals. I don't know. It's like everything. So I thought that showed a lot of wisdom on her part, just knowing that we're not separate from nature. It's something that's part of us and who we are, because light and water goes through us just like through plants. So nature close to home was something that we found was an important ingredient to a nature-based social prescription for this population. And here's the final celebration I mentioned with some of our students, showing their pictures and having some sparkling cider together and just enjoying being together in a moment when we were also separate in the pandemic. So the phase 2, I'll describe next briefly. This phase 1 led into the larger survey at a health clinic for young parents at the Children's Hospital of Colorado. In this survey, we built based on our MINT findings from phase 1. We just wanted to know, to dive deeper into some of these themes of what would a nature-based prescription look like for this population. We had 131 participants, average age was 19. Over half had completed high school. Most are living with their family. And similarly to our smaller MINT population, most were non-white. We wanted to know how close this population was to the natural world. So we used a special measure to demonstrate their connectedness to nature. We found the average score was 3.9. So to give a lower score would be 1, a higher score would be 6. So to give some perspective, 3.9 is higher than some other studies with young populations. You can see it's higher than a study with Canadian undergraduate students, Canadian middle managers, another study with German secondary school students, and higher than 450, a study with 450 Ecuadorian high school students. So a strong connection to nature with the survey population. We also wanted to describe this population's level of loneliness. So we used a 3-item loneliness measure, and the average score was 4.78. You can see here that was relatively high when compared to the same measure used with other isolated populations. So it was higher than 175 Americans measured who had spinal cord injuries, higher than 1,000 adults during COVID lockdown in the US, and much higher than 2,000 elderly Americans who took the same measure. You can see here, so this population could be relatively moderate to, we'll say moderate to acutely lonely. Okay, our final part of the survey, we wanted to know what were their barriers to getting outdoors, if there are any. So how could we help remove those barriers? The top barriers are seen here at the top: no time, no one to do the activity with, no energy, or feeling self-conscious about my looks when I do the activity. So interesting barriers there. We also asked, this was a fill in the blank question, what are your favorite outdoor activities? I thought this was really interesting because 2/3 of people wrote in either walking, hiking, or running. So that's much higher than any of the other options you see here: team sports, meditation, art. So that could be a very simple nature-based social prescription for this population that could be preferred. So based on MINT findings, these 2 studies that I described, what did we find and how does this help inform what a nature-based social prescription could look like for this population? As I described, excuse me, This designing an intervention for loneliness that's nature-based for this population, it should ideally be close to home, school, or childcare to match that nearby nature interest or the lack of transportation and the busy lives that they have. It should be brief, low to moderate physical exertion. It should require low to moderate physical exertion to match that low energy barrier that I described earlier. It should be group-based to capitalize on the success of the MINT group, the belonging that they felt. Walking or hiking or jogging would be great choices. And also that it incorporates family, that family as friends part we described earlier. And definitely should include a mindfulness component to help relieve some stress that these young parents feel and to match their interest in meditation. And there's several programs that we could look to for models when we think about what a nature-based social prescription could look like. In the US, there's a program called Walk with a Doc, where a physician would meet with local residents in a park in a given area. I think there's about 500 chapters of Walk with a Doc in the US, and there's an educational component, and then they just walk with the doctor for a while together. But we find that this lacks this group bonding sort of component that MINT really leveraged. So a similar program in the UK could be Green Social Prescribing, that's growing more, leveraging this group dynamic and time in nature with others. So just a few examples there, but that's my presentation. Many thanks to my advisor, Dr. Jill Liff, for her continued support of my career and my learning, and all the many funders and supporters of this dissertation. So with that, I'll end the presentation, and thank you very much for listening.
Myself up there. Thank you, Ashby.
Okay.
One of the things I find so valuable about the MINT study is that you showed how connecting with nature in a group with all of those benefits that your study shows, and the studies by both Nooshin and Jill, you've shown how to integrate it into a school setting in a way that it just kind of fits into the school curriculum, and yet can have clearly such a valuable impact. And as I recall, the young participants in MINT all wanted to continue. They wanted to keep on doing this. And another thing that strikes me about it is that this is very simple, nearby nature.
Yes.
It's what is already there. And these are working class neighborhoods, as I understand.
Absolutely.
And yet that nearby nature that these young people could have found it so meaningful. And Jill talked about the importance of the aesthetic experience and the emotional experience of being out in nature, and that they were able to find that in the nearby nature in there.
Absolutely. Yeah, I think just seeing that it was really important in the study to show that these students already had a close connection to nature. It wasn't something that needed to be taught or shown. It was already inside of them, and a really longing and passion that they had inside. So it was really fun to give them some time in their schedule to really open up to that.
Yeah. And you provided an opportunity for that within the curriculum, and also I think affirmed its importance, and
Absolutely.
to help educate them that this is really valuable preference to have time in nature, and good for them, good for their young children. Also, I hope they'll carry that forward with their children.
Absolutely. Yeah, that's a really good point to hit at home. Thank you.
Our fourth speaker is Dr. Wesley Tate. Dr. Tate is a board-certified psychiatrist in Colorado. He has worked with veterans, adults in recovery, families, college students, and children. Dr. Tate created Pathways, a first-of-its-kind group therapy program that promotes connection with nature as a source of healing for mental health in Boulder, Colorado. Dr. Tate is the medical director of the Trauma Foundation, where he works to bring innovative mental health programs to diverse communities across the country. Welcome, Dr. Tate.
Thank you, Dr. Chawla. It's a pleasure to be here today.
Pull up your screen.
Let's go.
All
So,
right, we're ready to go.
all right, sounds good. Welcome everybody. I'm glad that you could be sharing this video with us. I'm going to talk about some nature-based healing programs today. Next slide. Just to let you know what topics we're going to be covering, I'm going to focus in on a comparison between nature prescribing and nature programming. These terms are often used interchangeably, but I hope that as a result of this presentation, you'll understand some unique differences between them. And I'm going to highlight two specific programs. The Park Prescription Program is an example of nature prescribing, and the mental health program that I developed here in Boulder, Colorado, called the Pathways Nature Healing Program. Next slide. So I wanted to find some terms before we begin, as we're going to be using the terms nature and nature experience as they relate to nature prescribing and programming. I would just want everyone to have a reference point. These are very broad and inclusive terms, as you can see here on this slide. Next slide. So we want to really dive in here and try to piece apart the difference between nature prescribing and nature programming. Nature prescribing refers to a physician or other healthcare provider giving an actual written recommendation or prescription to a patient to spend time outside. Nature programming, which has previously most often been described in the literature around learning environments, I define as programmed activities in nature with the intention of supporting mental and physical health or both. And we'll illustrate those coming up. Now, Dr. Chawla has written, I think, a very stimulating piece looking at the difference between passive exposure and active engagement. And when I first read this, it really resonated with me as a mental health provider because I saw the difference between passive exposure and active engagement similar to the difference between medication for mental health problems and psychotherapy for mental health problems. And I think that the idea of taking medicine is a form of passive exposure is a good analogy. And I think doing psychotherapy as a form of active engagement is a very good analogy for the model of nature programming. And I would say what I say to patients is that these are not only different processes, but they result in different outcomes. And so that's what we're going to be taking a look at today. Next slide. Now, I want to give some concrete examples of real world case studies of what these models look like in practice. One of the best known nature prescribing models in the United States is the Park Prescription Program, which has been going for over 10 years. And they define their mission as to decrease the burden of chronic disease and foster environmental stewardship by using prescriptions in nature during the routine delivery of healthcare. And so we're going to see what that looks like. Next slide. It literally, this is sort of a graphic that they put out to illustrate the heavy cost and burden of chronic disease, and based on the research literature, some of the known benefits of spending time outdoors. Next slide. They share this information with primary care providers in order to educate them about these potential benefits in the hope that they will recommend time in nature as a lifestyle modification or behavior change that their patients can adopt in order to improve their overall health. And it literally looks like walking into a general practitioner or primary care provider's office and receiving counseling and education around the health benefits of nature experience and being given either a map to local parks or green space, or what you see on the right side of the slide, an actual written prescription to tell patients where to go and how much time to spend outdoors. Next slide. Now, I want to contrast that model of a nature prescription program with what we're calling nature programming. So this is a mental health intervention that I created in Boulder, Colorado, at the hospital where I worked at the time, Boulder Community Health. And it is a recognized treatment for mental illness. It takes the form of what's called an intensive outpatient program and a partial hospitalization program. And those are types of mental health treatment that address a wide variety of mental health problems, and they are intensive models of nature-based group therapy. So they take place outdoors in a group between 12 to 15 patients usually, and the groups spend up to 4 hours a day, either 3 to 5 days a week, depending on whether the patients are participating in the intensive outpatient program or the partial hospitalization, which is a little bit more intensive. Next slide. The Pathways program uses a diverse variety of nature experiences, and we partner with 2 community partners, specifically Boulder Open Space Mountain Parks, which manages a lot of the green space, trail systems in Boulder, Colorado, and a community biodynamic farm called Lightroot Community Farm. And participants can engage in different varieties of experiences in each location. Next slide. This is a short video that we developed for the Pathways program. It gives you a little bit more of the actual flavor of what the program offers.
There's a transformative power to being in nature. Immersing yourself in nature allows you to be present and mindful. There are real physical and mental benefits to spending time outdoors. It can reduce stress. It helps improve attention and leads to greater focus. It can also enhance creativity and curb negative thinking, all of which facilitates positive effects on your mental well-being. At Pathways, our goal is to use the healing power of nature to help you live a more fulfilling life. Many people face mental health challenges that keep them from living to their full potential. Our mindfulness-based nature therapy programs are designed to help if you've been struggling in life. If you're looking for a way to break free from negative thoughts and habits, and you want to connect with others who have similar experiences. If you feel at home in nature, more relaxed when you're outdoors, you enjoy hands-on experiences shared by a group of like-minded people, and you're looking for greater control and balance in life, but need guidance to help get your life back on the right path, then Pathways may be right for you.
The intention of Pathways is to provide a healing space for you to overcome the challenges you're facing. We offer an opportunity to help you find positive solutions in your life. Our group therapy sessions connect you with others facing similar struggles, so you will have support to help you in your recovery journey while doing activities in the natural beauty of our local community. You'll be creating new experiences in nature that aid in well-being and build off those positive experiences to facilitate awareness and growth, to help you overcome feelings of isolation and loneliness, and help you foster a sense of meaning and purpose in life so that you can begin a new path forward.
So now I'd like to dive into a comparison between these 2 models and draw out some similarities and some differences. And I'm going to use 4 categories. And the first one is going to be patient engagement. Patient engagement, as we typically use it in the healthcare system, really involves 2 components. One is adherence and the other is activation. Adherence is people's completion rate. So do they participate fully in the program that you're offering, or utilize the experience that you're recommending? And activation is, what are the long-term effects of having had the nature experience? How does the experience get incorporated into people's lives? And I would say, as we compare these 2 programs, the nature prescribing experience has some struggles with activation and adherence, in that not everyone follows through on the recommendations that they're given by their primary care provider, and there's not currently a standardized way of kind of following up and understanding the impact that these experiences have on people long term. By contrast to that, in nature programming, it's a more structured curriculum, and people are actually engaging in these activities in a very formalized way. And so we can actually track some of the improvements. We do notice, particularly with the Pathways program, that adherence is much higher than for similar other mental health treatments. And because the programming actually doesn't rely just on the nature experience, but on the benefit that people get from the nature experience, that's something that they actually can carry with them. And if you remember back to Dr. Chawla's descriptions of active engagement, it involves improving people's capacity and capabilities around several psychological needs like autonomy and relatedness. And those are things that people carry with them and can continue to work on even after the nature experience episode has passed. And they can return to nature, obviously, to continue working on those goals. Next slide. Now, when we look at the breakdown in terms of program leadership and community partnerships, the thing I want to highlight is that in the nature prescribing programs are heavily dependent on solo providers, on primary care providers or general practitioners who really support and champion this program. Nature programming offers multiple avenues for people to participate in leadership roles. That includes the co-facilitators of the groups like park rangers, naturalists, other outdoor educators, but it also provides avenues for leaders in community organizations to participate in directing the overall program. It also gives participants avenues to participate as peer mentors and as volunteers after they leave the program with some of the community-based organizations. Next slide. Now we're all, I think, on both sides of the Atlantic concerned about the workforce shortage in healthcare, and particularly in mental health care. I know it's a big issue with the NHS, but here in the United States, it's an issue all across our country, and many commentators and public health experts have commented on the long-term effects of this severe worker shortage over the next years and over the next decades. So how do these two, nature prescribing and nature programming, interact with this workforce shortage issue? As I said before, the nature prescribing program really depends upon solo physician leaders or clinical champions to take on the responsibility of advocating for these programs within their health systems and also sustaining these programs by their work effort, which can take a pretty heavy toll on providers, and that has its effect in terms of increased stress, work-related stress, as well as the potential for burnout. Now, nature programming models also depend upon the leadership of healthcare providers, but the responsibility is distributed among a diverse group of co-partners, essentially. And like I said before, those could come from community organizations that we work with, community team members. Those co-facilitators of group really become a workforce multiplier. And so we draw upon groups of non-licensed community workers, naturalists, park rangers, outdoor educators to help mitigate the shortage of trained and licensed mental health workers. And that collaborative model is very beneficial, I think, for delivery of care and treatment. Patients and participants seem to really enjoy getting those diverse perspectives. And long-term, I think it's also going to be a significant alleviator of the burden on the workforce to provide services. Next slide. Finally, I want to talk about the financial sustainability of both models. This is obviously critical if these programs are going to get widespread adoption and if they're long-term going to be successful. The nature prescribing model really does depend on new revenue streams coming into the healthcare system. And I think that that's true, not just in the US model, but even in models where there's more public support for healthcare services. They are finding it difficult to deliver funding funds to actually keep these the workforce paid and to hire new professionals and also to keep these programs going. In the US, programs like this struggle to get support either from philanthropies or from charities or hospitals actually making up the cost of these services because they're not getting reimbursed from them. Now, the nature programming model is very different because it is a recognized form of mental health treatment that is fully reimbursed by commercial insurers and by Medicare and Medicaid. That means that its revenue stream is much more solid and guaranteed, and that health systems and community organizations don't have to chip in to cover the cost, so that their revenues can go towards promoting services and growing their organizations. And that's, I think, a very important distinction. That may change. New revenue streams may come online to support nature prescribing, but there's no guarantees, and that's a huge risk factor, I think, moving forward. Next slide. In summary, I want to say that I don't think that this is an either-or proposition. I'm not, the purpose of this comparison isn't to show that one type of programming should take precedence over the other type of programming, but to give people an idea of where each type of programming might fit overall into a system of preventive care, public health, and mental health treatment, as well as general health care treatment. And one analogy that I might use is that I think, based on everything that we've said about the nature prescribing model, where it might best fit into a holistic system would be as a model of prevention. So it's a model of lifestyle modification, behavior modification. I think it's similar to the recommendations we've been getting around, eating healthy. And so eating 5 portions of fruits and vegetables every day. It's a guideline, I think, similar to that, in that it's something that we can do on a daily basis to improve our overall mental and physical health. And then if we see it like that, it is sort of like treating our bodies and our minds in a way that promotes the best health and is more likely to prevent long-term illness or disease. I think the nature programming model fits very well into an early intervention and treatment model. And in that it is a program that requires active engagement for participants. They usually do it in some time-limited fashion, although it can be revisited, and that it draws from a wide range of providers, not just healthcare providers, to address people's overall, not only mental and physical health, but also their social and emotional well-being. And I think that's a great model for helping people that have been identified to be struggling with either health challenges or mental health challenges, and to get them resources sooner so that those problems don't progress into more serious problems, but also to help people who have been actually diagnosed with a mental health problem or with a chronic illness to get treatment that can help alleviate their problems and maybe reset them into a better baseline of functioning. Next slide. The information that I provided today depends upon a wide range of research from people who've been studying the benefits of nature and learning and growth and development in nature for a long time. Here are some of the articles in the literature that I've most appreciated and used, and I encourage everyone to look those up and also to follow some of those investigators in their other research as well. Next slide. I want to acknowledge all of the people who've contributed to the work that I've done, particularly those who supported the Pathways program in Boulder, Colorado. Without the help of our community partners, this program wouldn't exist. I also want to thank the thought leaders in this field, 2 of whom you've met today, Dr. Louise Chawla and Dr. Jill Litt, for their perseverance and for the knowledge that they've helped spread and educate people around the globe. I want to thank those funders who have supported the Trauma Foundation, which is where I do most of my work in bringing new and innovative services to folks around the country. Chris Rutgers is the founder of the Trauma Foundation, and I'm very grateful for his support as well. And I think that's the last slide. I want to thank everybody for being here today. I hope that this information is useful and that you can take it and use it in your communities to promote a broader range of nature experiences that actually address people's problems, not only those who've been diagnosed with health issues or with mental health issues, but to help prevent people, particularly children and young adults, from developing those issues in the future. So I want to encourage everybody to get out in nature, to experience those benefits, to engage in activities that are nature programmed whenever possible. Thanks so much.
Thank you so much, Dr. Tate. Jillette has made the comment that there's not really clarity about those 2 terms, nature-based social prescribing and social programming. And I found it very useful, the way you really thought deeply about it. And I think many people will find this work useful. it occurred to me as you were presenting that maybe there's something in between, which would be nature counseling to get people out in groups in nature. I think that would be a kind of intermediary model that we really could look at too.
Yeah, I think that's a great suggestion. I think the group model is really important. I think there's one thing I didn't mention in the slides is the social connectedness piece. And there's a lot of research into how the social relatedness piece actually promotes better health by mitigating some of the epidemic of loneliness and social isolation that people are experiencing, particularly post-pandemic and particularly among our young people. So I think that would be a great way, particularly if it was focused on reaching young people where they're at, and whether that's schools or pediatricians' offices or community organizations that do volunteer work. I'd be a big advocate of that.
Great, good. All right, so much to do, so much more to do. Thank you very much.